Good afternoon, everyone. My name is Kevin Jacobson with the Wisconsin Office of Rural Health. We're a program at the University of Wisconsin School of Medicine and Public Health. And I want to welcome you to today's webinar, Preparing for Wisconsin's Rural Technology Transformation Fund. The fund is part of the Rural Health Transformation Program, RHTP, something you might have heard a little bit about over the past several months. A couple housekeeping issues. As Mary said, it will be recorded and sent out. Also, if you have any questions, please put them in the Q&A and not in the chat. So our presenter today is Dr. Jonathan Neufeld, Director of the Great Plains Telehealth Resource and Assistance Center at the University of Minnesota. And with that, I will turn things over to Jonathan.
All right, thank you, Kevin. And welcome, everybody. I am going to share my slides here, and then we'll get started. Thank you, everybody, for attending here. I want to say just a little bit about who we are first to get us started, and I can preempt some of the questions in that by saying that the slides will be available. We'll be sending them out to everybody who's registered for the webinar. So if you're, so you don't have to feverishly be taking notes or have your little chatbot friend take notes during the presentation, at least not as far as the slides go. You'll have access to those. And also just to note that our work at the Great Plains Telehealth Resource and Assistance Center is supported by Health Resources and Services Administration, the Office for the Advancement of Telehealth. We are housed at the University of Minnesota, but funded through, like I said, the Federal Office for the Advancement of Telehealth within Health Resources and Services Administration. There are, just to give you just a little bit about the telehealth resource centers, there are 14 of us, 12 regionals. This is our region we cover. You can see behind me. It includes Wisconsin, of course. And you can see on the map that there are other 11 other regions across the country. All of us have information on various aspects of RHTP as well as all different aspects of telehealth. Because telehealth is such a big part of the Rural Health Transformation Program and grants, we're all sort of in overdrive here, working with organizations, working with folks on thinking about what their projects are going to be and how to evaluate them and all of that. And the other thing that I would say about us is that yes, we have a lot of information that you can download. For example, we have a policy page that includes, this page happens to say Nebraska, but you can see all our states are there. You put in /Wisconsin, you'll get the Wisconsin resources page. We have a billing guide, we have some brief guides, we have a bunch of other resources as well. And that's all great. You're welcome to download that. You're welcome to download resources from all the TRC sites. And I have a link for that to all the sites at the end of the webinar. But what I want to say is that our primary value to you, I mean, if you want to download stuff and read it all day, all week, whatever, that's great. That's fine. Help yourself. But we can be very valuable, more valuable, I think, as direct consultants, which again is all free. All of our work is free. We're not going to charge you for any of it, but call us and let us know, or send us an email. Let us know what you're trying to do, what you're trying to accomplish. Let's set up a meeting. Let us walk you through it, and let us be your librarian, your concierge, your guide to the information that we have and what we can provide. Because what we've found over the years is that every project is just a little different. Every organization is a little different, and there are certain aspects of telehealth or of a certain project that are critically important to you, but maybe not the last group we work with. And so it's really important to give us detailed information so that we can provide detailed information back. So we're not we're not surveilling anybody. We're not, recording all of this and sending it off to Washington or wherever. But we can help a lot by knowing more about the specifics of your specific program. We get asked a lot of general questions like, is telehealth reimbursed or is RPM reimbursed? And the fact is, even responding to those questions is more nuanced than you might think. So it's helpful to know in what context and with what payers and geographic regions and all of that sort of thing. So let us know how we can help. Reach out to us. I will say that again before the end of the presentation. Um, so here's the bad news. We're all waiting with bated breath, but this is probably not the webinar you're looking for. We wish it were. We are waiting like everybody else to know details. I was just on the RHTP site this morning, and that's as good a set of information as I have. It's the same that you have. We're waiting we understand that very, very soon information is going to be uploaded about RFPs and some of the grants for year one. But this is not that webinar. So sorry to disappoint you if this is what you were hoping for. Finally, some information, finally a live body to say what's happening. Sorry. But what we can do today is plan a few things. We can review what we know. We can make the best preparations we can, and we do have some thoughts. I do have some thoughts on how to prepare in the context of uncertainty. And we're as soon as we have RFP information, as soon as we know some more details, then of course we can be of more help to you as we all kind of dive in and figure out where we're going to go with this. So let's take a look at what we know so far. This is the number, $203 million, 203,670,005. Not sure what the 5 is for, but somebody had to calculate a number. Actually, I think there are even cents on here, but what's a few cents among $100 million, $200 million? But I wanted to just take a look, and so I had my friends in the AI, my little elves in the AI workshop, generate this for me. This is a graph of Wisconsin DHS, Department of Human Services, taking out all of the federal Medicaid money, matching money that comes through, and that's the bulk, that's the lion's share of the money that they handle. But if we ignore that, set that aside, and we just look at the things that Wisconsin DHS does, besides passing through federal Medicaid dollars or spending Medicaid dollars that are reimbursed by the state, this is what it looks like. And so you can see there's big chunks of money for state institutions, community mental health, public health, aging and disability, a number of other things. That blue bar is the Rural Health Transformation Program, that $203.67 million that I just mentioned. And it's a pretty big chunk. By way of comparison, you know this all. I'm not telling you something new, but I just wanted to get a visual. But by way of comparison, I dropped a couple of other things there in the right center of the screen. The Wisconsin Department of Revenue, that's your state IRS, right? The folks who collect all the taxes across the state. That's $420 million for that whole. That's not what they bring in. That's the staff. That's the budget for the department that brings in all the money. Your state National Guard is $285 million. Okay. And the RHTP program is 203. It's a big chunk of money. Again, you know that, but I just wanted to put it in perspective how much is going on in these RHTP funds. And every state across the country is struggling with this. We just had our conference a couple months ago, and had a breakout session on RHTP. We had folks from NOSOR and some other national groups come in, as well as a couple of state groups. Every state is struggling mightily to figure out, how do we distribute this? How do we handle this much money responsibly? And Wisconsin is no different. So they're working through the Office of Grants Management. There are more than one of the specific line items that they have in the proposal is money to set up a grant management system within a department or a sub-department or within a group. So you know that this first time around, this first year, is not going to go as smoothly as we're going to hope. but they're going to do their best, and they're working within some tremendous constraints from the federal level. And trust me, we have heard this from every state we've talked to. The national folks have heard this from every state they've talked to. The constraints put on them by the federal government in spending this money are huge. This is a timeline. This is out of the state's PowerPoint on this. And you can see that they put out, they planned for the money, they collected applicants from each state. The state Wisconsin RHTP page has all of their application materials and the grant that the state received. All of that's what you see, and we are now in this TBD section of the timeline, which is the TBD part is doing a lot of heavy lifting there. We are trying to figure out what's going to happen in this session or in this section of time and when that time starts actually. So hopefully they will determine it soon and let us get started. But I also wanted to point out they are under a huge hard deadline at the end of August. They have to report some things back. And so this is the first big point I want to make as we're talking about preparing for these grants and how do you structure these grants and how do you put it together. And I'll say this probably more than once, but have some early wins that you can record, that you can put a number on, quantifiable things that you can do within the first month or two of getting your grants, assuming you get them, so that you can report that back, because by August, the state is going to have to report to the feds what they're doing. And of course, the projects aren't going to be done. I mean, nobody expects all of these projects to be done by the end of August. There are some hard deadlines on that too. Money has to be expended and all of that, but have some quantifiable numbers that you can get to very quickly. So for example, we're going to hire a bunch of new people. Well, can you at least count how many job positions you've posted by August 31st? Or can you at least say how many job descriptions you've written by August 31st? Or how many planning meetings or how many jobs you've enumerated? Something, some part of that longer process that you can count and submit, because you don't want that report to say, yeah, we're working, the project seems to be going great, but we have nothing to report yet as of August 30 or 15 or whenever it's due. So have some early wins that you can count. All right, you've all seen this slide probably from the state's website. You know that the state is working on three major areas: workforce grants, technology grants, coordinated care or care coordination grants. I just want to review what we know about those three sections and then make a few general comments. So year one, workforce grants. You look at what they're proposing to do. There's $53.5 million that's going to go to a collaboration between AHEC, Area Health Education Centers, University of Wisconsin, Wisconsin Technical College, Marquette, Medical College of Wisconsin. Big educational collaborative, a lot of money. Remember, they had to spend $200 million in the first year. They need to know who are some large, legitimate organizations that we can count on to work together to do a big thing and spend a bunch of that money with integrity. So that's a big chunk going to them. I'm assuming none of you are on this call. Those folks better be working on their act with some other people, probably who aren't free, some consultants who aren't free, working on that, spending that $53.5 million. We're not going to talk about that because that's not us. There is, however, a $25 million set of grants for community health worker programs through competitive applications, and a $5 million set of grants that are also competitive, that are workforce development grants through a structure, an existing structure in the Department of Workforce Development. So those are something that we can expect information on. I'm going to move on to the second section here. There's a technology section, and again, a big chunk, biggest chunk of $69 million going to competitive grants to rural facilities for technology improvements, including a key vendor to build a backbone. Okay, so we can imply a few things or infer a few things about this. Number one is there's going to be some big vendor that goes after a big chunk of this $69 million. I'm going to assume that's not any of you on the call. They're working already to compete for that backbone job. And probably a lot of the grants in this bucket are going to be determined or dependent on who that vendor is, and that vendor, I would assume that the state would be working with that vendor once they're chosen to specify the rest of the project and what's going to happen there. What are some of the choices? What are some of the contingencies and all of that? So I'm going to say a little bit more about this a little later on. The second chunk here, 13.6 million, is again going to an existing collaboration with some existing partners. We're going to assume that none of you are these folks. They're named partners, so that money is going to them and they're going to do that thing, and we're not going to talk about it. And then finally, in year one, care coordination. A set of $10 million set of grants, competitive grants going to regional partnerships to develop mobile clinics, telehealth programs, access points, co-responder behavioral health programs. These are, I want to say a little more about this. A couple of things we can note. Number one, regional partnerships. Okay, these are grants that are intended to support groups working together. So this is not you putting in a telehealth program at your clinic. This is you and another clinic or a hospital or a somebody. It's a regional partnership. So the ideas here that they're looking for, again, I'm guessing about this. I don't have any inside information, but if I were writing this and this is what I wrote, what I would be thinking is these are collaborations and you need to find partners. You need to have partners that you're already talking to about doing this kind of work. And the kinds of goals, the kinds of projects that they're looking to fund are things that move the needle regionally in terms of healthcare access. So a mobile clinic that serves a region, that you partner, a clinic and a hospital partner together, two hospitals partner together, a rural health network partners, among all of its members, whatever. A telehealth program that brings in resources from, some urban centers, but makes them available to a collection and network of rural providers. And access points, or a series of access points that are shared. Maybe they're at libraries, maybe they're at other public buildings somewhere in, a collection of 5 counties that allow patients to go in and have a private place where they can see any provider by telehealth if they don't have access to a private place at home and don't have connectivity, or for whatever reason, telehealth is not a good option. Or a series of access points within clinics where patients can come in and there's a collaborative to develop a way that the patient can see a provider that's not in this clinic or not affiliated with this hospital. Maybe that's a bit of a stretch. Most healthcare organizations aren't thinking of those kinds of things, but these are the kinds of collaborative efforts that are implied by a grant worded this way. Co-responder behavioral health programs, in case that's not clear, these are the kind of things where, for example, mental health practitioners ride along with first responders, maybe the police department, maybe EMS, to provide mental health support to patients in their homes, in their home communities, to avoid a ride, avoid a jail, an overnight in jail, avoid some sort of other problematic response that could be rectified or at least ameliorated by the presence of a behavioral health access person. So those are the kinds of programs that are implied there. $4 million to the Office of Children's Mental Health, again, off the table for us. We're not after that. And then $9.5 million to the Office of the Commissioner of Insurance in Tribal Nations. There is a program. I just saw the chat. I'm sorry, let me finish my sentence. There's a program working with Commissioner of Insurance of Tribal Nations. They're trying to enhance and extend and improve Medicaid in a number of ways. So that project is already underway, and we're not going to be talking about that. Looks like the email. We're going to see. I'm going to watch the number and see if everybody jumps off the call. But an email about the RFPs just went out, and probably they're posted online. So we had expected possibly something like that today. So hopefully, if you want, you can drop off and go see that and see what's going on there. Otherwise, I'll continue talking about, or letting you know what we're thinking about as we're looking at these opportunities. So your target grants, of all those areas, just to summarize and pull it together, in the workforce domain, there's $25 million out there for community health worker programs of various kinds. Okay, the Wisconsin Association of CHWs is going to be heading that up, or at least have some sort of a significant role there. And there will be grants to other folks using CHWs in various ways. There is 5 million for work. These are probably small direct workforce development grants in the existing DWD program. So you can get online with DWD and see what that's like and what those applications are like, probably. There's a big technology grant, which I'll say more in a second, and then there are care coordination grants for regional partnerships at using telehealth programs of various kinds and other types of technologies to build access across regions. Just one more thing about the year one technology grants, and hopefully I'm not now that information is out there. All of this, well, could be at risk anyway, but my speculation may be moot. But I suspect that when the state has to develop grants this large, and in a coordinated way, technology can't just be buy whatever you want and plug it all together, because there's going to be a central coordinating agency and there's going to be a number of pieces that have to work together. That they will probably follow some sort of existing structure. And the most obvious one, I think, is probably the Rural SHIP program, where there are allowable expenditures, a structured reporting mechanism, a timeline. I mean, these are the kinds of constraints that you're going to be operating under, and presumably they'll be pointing to those that series of constraints and allowables and reports on all of that in the RFP process. So that's just a primer to get you thinking about what might that look like. So it feels a little less vague, a little less random, a little less anything could happen. It's probably going to look like some of the federal state programs, pass-through grant programs that we're already working with. So given all that, how do we prepare? My apologies about the drawing here. It is a sort of an obscure reference to making decisions without enough information from our friends in the AI workshop. But this, I think, is very appropriate quote here. The reality is you make decisions with imperfect information and you achieve imperfect results. That's kind of where we're working from here. The alternative is to not make decisions and not achieve anything. So, and this is AI using imperfect information to achieve whatever results it can in developing a picture of a handshake. This went around for a while. If you haven't seen this, sorry. If it creeps you out, sorry. But for a long time, AI couldn't make a decent handshake picture to save its life. All right, so how do we prepare for granting, preparing for adoption? These are some general information, some general thoughts about implementing telehealth that we have learned over the years. And of course, the question always is, we've done this before, we've done it a number of times, how hard can it be? Well, if you've ever adopted a puppy, just saying, it could be hard, could be challenging. Here's some things that we have found help organizations think through this. These are going to be general exhortations, I know, and it's going to be me sort of bloviating about, good ideas. And you all are leaders in your field and probably have your own good ideas. So this may not be a lot of help, but I want to at least mention a few things and call out Ingenium Digital Health Advisors, who have been, Christian Malaster and his group have been partners for years and years. A lot of this material is just cribbed directly from Christian. He puts out so much good information, a banger every week on telehealth, and his website just gives away free stuff. He's running his own private telehealth resource center. So he's just a great resource. So calling out that resource and giving him credit for the stuff I'm going to talk about. In Mindset Shifts, we talk about several things, but one, diagnosing before we treat, a priority of outcomes and technology, and then product, which I'll say more in a second, implementation, not procurement, it's a big difference, and providing, not launching. All right. Diagnosis before treatment. You've heard this in motivational or other kinds of surveys or webinars before, but of course we want to know what is the outcome that we're after, and we want to focus our projects, telehealth projects, no different than any others, focus on what is it that we want to achieve. What is it that would make life better? It's not just we want to buy this product, but what is it that we're trying to do? Of course you've thought about this, but I'm just regrounding us. What is it that we want to have better? One of the exercises that can help with that is, what's your happy day scenario? What's the simplest and best case imaginable for how patients with chronic diseases manage? How do we support patients who have chronic diseases? How do we help them self-manage? Because in the end, they have to take the med, they have to do the thing that is going to help improve their chronic disease state, get the exercise, use the inhaler, do whatever. How do we best support that? And how do we make that the simplest and seamless, as simple and seamless as possible? So we have to think through, what is our happy day scenario? And how will we know when we're there? There has to be a number. There has to be a way to quantify. Find some information that will let us know that we're making progress, and we'll know when we've hit it, or at least when we're moving the right direction. A second set of priority, or a second thought, mindset shift, is we have to be grounded in outcomes before we start talking about products. Outcomes, what is it we want to achieve, will then suggest what are the technologies that support that kind of an achievement, a change. And then within that group of technologies, what are the products that we want to look at? We don't start with the product. Oh, that's cool. I wish we could do that. I wish we had that. You start with, what is our clinic? What do we want our clinic to look like? What do we want our hospital to do differently? Is it global? Is it just specific? Is it just this department we want to increase the numbers? Or do we want to we want people to have a different experience of access in working with our health system or our hospital or our clinic? And so thinking those things through can help ground the product discussion. Second thing is, I say this a lot, and of course, I'm a clinical psychologist, so this is all, touchy-feely kind of crap, and you can ignore it. But in my experience, telehealth technologies are all about supporting various kinds of relationships. Now, they may be good relationships or bad relationships, and it's not just, kissy-huggy relationships, but work relationships. It is about supporting people to work together better. Sometimes that's provider to patient, delivering clinical service. Sometimes it's staff to patient, like we're supporting things, or we're scheduling the call, or we're filling the meds, or whatever. Sometimes it's staff to staff, like from one office to the other, from billing to the front office, or but all those are various kinds of relationships, communication of various kinds, and the tech is supposed to support that. Good tech brings people closer together. Bringing people closer together can sometimes cause some sparks and some friction and some tension, because I never have liked the way they did this. Now that we're working even closer together, that becomes the issue, or it becomes more to the fore. But the smoothness of that collaboration is what technology is supposed to support. So keep that grounded or at the center of that conversation. And then I think we have found over and over with telehealth technologies, the best product, there is no best product. There can be a best product for you, or a best fit for you. Think about, what is it that fits for you? What are the dimensions of a product or a service that are really what you want to do with it? And it keeps the focus on understanding yourself, your clinic, your people, your needs, your patients. What are the things you want to achieve with the technology, not just what are the cool things the tech can do. Third, and Christian makes this point a lot, and he's so right about this, we make this point a lot too now. Implementation is not just procurement. Buying stuff and installing it and configuring it, that's step one. But step two, and the bigger step, is how do you make it do what you intend for it to do? And there is a whole science around this, a whole way of structuring and measuring and observing what we're doing. And there are better ways to do it and worse ways. And a disciplined framework of any kind is way better than just figure it out. Giving people the equipment and saying, you'll figure it out. Helping them work through and developing a structured way of implementing is super valuable, invaluable in the sense that you cannot figure out how valuable it is because it is so valuable. All right. Stakeholders have multiple needs. They don't just need an explanation. This is what the picture is about. Direct the rider, motivate the elephant. That's the emotional side of people. They want to be achieving something. They want to feel something about doing this new project. Shape the path. Make it easy. Make it possible. Make it clear what they're supposed to do, what people are supposed to do in implementing change. This is taken directly out of some of Christian's work. Build a robust reusable skill set. This, I want to underscore this, my colleague Mary Devaney just underscored it to me a few moments ago. This is year one of a 5-year process. You're going to be doing this for a while and even beyond these 5 years. So if you can figure out how to build a robust, reusable implementation skill set, you know, how do we assemble the team? Who owns this project? Who are all the stakeholders? What are the steps? How do we identify the steps, milestones that we're going to measure? How, when we're there, how we get there? Doing all of that is really a superpower for an organization, for all kinds of different organizations. I was just talking to a hospital CEO the other day who has been working on this for years, and she was just so pleased, so tickled that her people now knew how to do this. Her biggest complaint was, I keep getting these great skilled people and then they keep leaving and I have to bring someone else and train them how to do this process. But fortunately, you know, it was a tension, but fortunately, they had been able to keep on top of it and keeping a good team with a good set of skills that works together in her case. Excuse me. All right, and this is another one that is just so key. Proving or using proof of concept rather than just a soft launch or, you know, a trickle launch, because it's not just that we want to slowly ease into it. It's that we want to know that this project is going to work. A proof of concept says we're going to do a small version of this and we're going to test some critical assumptions and see if they're true. Is the technology compatible? Maybe that's one. Is the procedure that we imagine, is that how it works? Or does that procedure kind of fall apart as soon as patients from this other clinic start coming, or a different kind of patient starts coming, or the patient doesn't have a cell phone, or whatever? How robust is our procedure? And do we need to make sure that it's robust enough? Prove that our procedure is going to work. Do we know the patients are going to respond the way we think? Maybe they don't use this, maybe they use that. Do they have MyChart accounts? Do they have, you know, what they need? So you prove whether or not the patients are going to respond and what percentage of them are and how you increase their uptake. Are the providers going to respond? This is another one that I left off this list, but what are your providers thinking? You'll probably catch them in the procedural robustness part, but still, you need to prove the concept at a small scale and fix it while it's small. And then you can launch or roll out. But don't just, you know, you use a soft launch as a sort of acclimation period where we're just going to kind of get used to the new way. You need to prove assumptions so that, and financial sustainability, of course. You know, how do the payers respond? Do they pay? What percentage do they pay, etc. Because at the end of a proof of concept phase, success means that we, all the stakeholders, understand how the project works and are convinced that a scaled up version will perform as intended. Okay? That's success of a soft launch, or not soft launch, of a proof of concept, a limited rollout that proves that it will work at a higher scale and lets us all know how it's going to work. One of the things that I found as an implementation assistant support guide is that a significant percentage of your people will not understand how it's supposed to work until they see it working. This is not a fault or a weakness. It is just that some people work with what's in front of them. I have this joke between me and my wife. Sorry for an anecdote, but I say I am a master of things that don't exist because I work in my head a lot. I imagine things. I come up with new concepts. I'm a master of things that don't exist. She, on the other hand, is a master of things that do exist. It's like, this is all we've got to work with. This is the process. This is the plan. And we work together well, and we have learned to enjoy it. But part of your staff are going to be very comfortable with things that don't exist, and part of your staff is not going to be comfortable until they see it concretely. So make sure that you understand that a proof of concept is a project, small slice of a project, small version of the project that at the end everyone's convinced, oh yeah, this will scale up. We see how this works. This will work. All right. A few closing points here. One, develop a coherent plan to improve care. Make sure you know what it is we want to change, not just what do we want to buy, what do we want to change? How do we want to be different when this is done? Second, focus on the outcome you want to achieve. Third, involve all stakeholders appropriately. Remember, this is long term. You don't want to do it badly and have people resent the first change because next year you're going to go after another one of these grants. And we want to be better at it next year, not more resentful of how it happened last year. Improve all the stakeholders and do that robust proof of concept stage. Identify some quantifiable, countable quick wins. In August, if not sooner, you're going to be asked, what did you achieve? Because your state is going to have to tell the feds what they've achieved by August 31. So have some quick wins there. And contact us for assistance, of course. We're available. We'll be as available as we can be to help pull those things together. Just want to leave our contact information here. We have a conference every year. It's in 2027. It'll be in early April. You can get that information as it becomes available on our website, gptrack.org. This link at the bottom, telehealthresourcecenters.org, that's all 14 of us, all the resources you want, or links to all the other centers, so you can reach them all there. All right, I'm going to leave that up while I go in to look at Q&A and see if we can address some of these. Just saw the email as well. Awesome. Okay. Year one, care coordination. Can tribes or tribal organizations apply to all three priority areas? Tribes were only listed on slide item number 3. My understanding, and again, I'm not the authority here, but my understanding, the short answer is yes. There are certain projects that are specifically targeted at tribes, but all the other types of projects, that if they're available to clinics, well, you're a clinic, or if they're available to hospitals, you're a hospital. So I suspect that the short answer is yes. There are probably some details, and the RFP may say something totally different, but that's what my understanding is. Kevin mentions the technology transformation funding RFP is expected at the end of the month. Okay, that's a big one, 69 million there. So it's going to take a little longer. It's going to be a little more structured. But thank you, Kevin, from Wisconsin. Though we expect those to be out a little later in the month. So fingers crossed on that. All right, click that off. Next one, Sharon notes technology grants. Can applicants include the backup IT infrastructure as eligible cost, network servers, cables? Yeah, sorry, I don't have those details. I suspect they will be in the RFP, and exactly what is eligible, that's what I don't know. The idea that there will be eligible and ineligible costs, that's the only point that I can make, and you probably knew that already. Okay, so now, Krista, I just want to confirm that rural now includes all FCCs despite not being rural, correct? So Madison, Wisconsin based is still covered. I'm not clear on that. If that information went out separately, I'm sorry. I'm not exactly sure what you mean. So reach out to us directly, reach out to Kevin.
Kevin has that information too, potentially.
It's quite possible that he does. Thanks, Mary. So I'm going to leave that up and just see if Kevin wants to jump in on that.
We haven't, as far as the technology transformation fund, as I put in the Q&A, that will not be available until the end of the month. And as far as the other funding opportunities, they were just posted within the last hour or two. So I don't have that information. I haven't had a chance to look at them yet.
Okay. Well, then what we'll say, Crystal, please reach out to us if any of it's unclear. After reviewing materials that are available, if any of that's still unclear, then just reach out to us, and I'm sure we can clarify that. Um, all right, Anonymous, what workforce is included under CHW? Yeah, okay, so this is an interesting kind of crossover if I'm reading your question right. The community health workers is a type of um, person that would do various jobs, but usually they are supporting, guiding, navigating, connecting with certain communities. Usually they have specific cultural or linguistic skills that help an organization connect with a minority community or some other group that a clinic specifically wants to reach out to. So it's not uh, uh, it's usually not indicated, and I haven't seen any indication that they're talking about a domain like EMS or like nursing care. I mean, a CHW almost by definition is not a nurse because they're a non-licensed person, nor are they an EMT or any other sort of licensed or certified workforce that you would use. But using CHWs to support an EMS service or a nursing service or a home health service or a mental health service or anything like that, those are the types of things we're talking about. A community health worker is, and there are plenty of resources at the website for the Wisconsin organization, Community Health Worker Association, I think it's called. Reach out to us if you have trouble finding it. But they are a type of resource, a type of person that has the ability to communicate with certain community and connect with certain subgroups within the community to grease the skids, to provide smoother access, to provide better interface with that community. And they get deployed in multiple ways. So that's the idea there. If you need more information, more details, then reach out to us. Excuse me again. All right, Brittany, when it comes to the Coordinating Care Grant, who do you think they are looking for to lead the application if it's more of a regional collaboration partnership? Good question. Short answer, I don't know. Long answer, if I were doing this grant, I would just make sure it's clear why we chose the lead organization that we did. Maybe it's the hospital and they're the lead and we're a number of clinics that refer into that hospital. Maybe it's a statewide association because, like the primary care association, because we are all rural FQHCs working together. I don't know that it's going to be limited one way or the other. I don't expect it to be, but I expect that you will have a justification for why you have a lead entity. It could be these folks have gone after a lot of grants like this, which the rest of us haven't, so they have the infrastructure, the accounting and administrative infrastructure in place to be the lead entity. You're just going to have to explain why you chose them and have good reasons to do that. And the reasons don't have to be a certain kind. There's not the right reason and a wrong reason. It's just there will be reasons, I'm sure, as you pull together your regional projects, why somebody might take the lead. And then explain your reasoning for that. That's what I think. That's how I would approach that. Again, if there's different information in the RFP, if it has to be this or that entity, then of course you'll know from looking at the RFP. I slammed this. What happened to my finger? Sorry, it's distracting. I know. I slammed it in a door, broke the end off. It's like no big deal. I mean, anymore. But yeah, try not to let it bother you. It doesn't bother me. Okay, if you already have grants in place, do you need to disclose those programs, and does this preclude us from reapplying through RHTP for additional funding? That's another good question because a lot of you, of course, have existing projects going on. What my experience is, and again, short answer is, I don't know. I haven't read the RFPs. You might have answers in there. But what I assume when I'm going after grants like this, the general assumption is if you've got a grant already doing, let's say, behavioral health workforce expansion, okay? And you're going to say, okay, we want to go after this grant to expand more behavioral health workforce. You just have to be very clear what is differentiating the two. Don't say we want to go after this money and dump it into the same bucket and do these same things as we're doing with the other grant. I know it feels a little artificial sometimes, but you have to say, okay, with this money, we're going to add 2 counselors and a community health worker to reach out to Spanish-speaking patients. And with this money, we're going to contract a psychiatrist or a psychiatric nurse practitioner to provide medication management, whatever. You just need to clearly differentiate so you can count separately. You know, how many sessions, how many encounters did we support? How many staff did we support? How many FTEs are in this bucket versus this bucket? So I don't know that you're excluded, and again, see the RFP for specifics, but at least be able to differentiate what part of the project you're supporting with this bucket and what part you're supporting with this bucket, and be able to count them separately. That's best advice that I can do at this point. Sharon, you may have already answered this in a previous question. Can the RHT funds, oops, sorry, my screen is zipping past. Can the RHT funds be used to lease telehealth equipment, cover software licensing fees, training on use of equipment, and/or certification of providers to use TM? I don't know what are eligible or ineligible costs. What I would say is you can usually assume that, you know, construction and remodeling are not in. As far as leasing versus buying equipment, I don't see any reason why they would care if you lease versus buy. Any cost, in my experience in writing grants similar to these, you just have to show that you have thought this through and that you have a reason why you want to lease instead of buy, or you have a reason why these costs are necessary to achieve what we want to achieve. Here are the things we want to achieve. Here are the things we think it'll cost to get there. This is why we need this money. So, I don't know if they're going to specifically line out, exclude certain things, but if you need to lease some equipment and then buy some software, license some software to run on that equipment, and then train some providers to do this thing, it's up to you to tell that story that shows, yes, all these things are necessary parts, and here's why, you know, we don't have it now, and here's what we intend to do, and here's how we will measure that it worked. We will double our access to behavioral health appointments from 200 to 400 or whatever, some way of measuring that all of these things contributed, and then, like I say, some quick wins to say, we have installed this software, we purchased this license, we put in these 15 workstations, we did these things very quickly, and now we're working on, you know, making sure that all of that stuff has the value that it needs to have for the long term. Again, I'm sorry, this is not the webinar that you wanted with all the answers, but hopefully we'll have a chance very quickly to look over to RFPs and perhaps provide some more information along those lines. Hazel, can the CHW grants be used to hire CHWs in a free clinic, for example, or is this a grant that is meant to be used by organizations like AHEC? No. My understanding is that these competitive CHW grants are for free clinics, for example, or clinic, you know, RHCs, FQHCs, hospital outpatient, whatever setting. If you want to implement a program to use CHWs to reach out to do what CHWs do well, then this is the program for you. That's what they're trying to support here as I read this. There are other things that the AHEC and the Medical College of Wisconsin and, you know, training programs like that are going to be doing, but the reason I see why they specifically said, you know, CHW's workforce development is for other organizations, not those, to be able to develop programs that use CHWs. So I think you're good there. My sound just went out. Okay. Kevin, also thank you, Kevin. Kevin is saying the CHW grant is one that was released this morning, so you'll have some details there. Thank you, Kevin. Okay. People asking questions of Kevin in the Q&A. Great. Care coordination. Okay, thank you. There's a link there. And you're welcome, Alyssa. Joel, if EMS doesn't fall under workers' workforce for, say, a community paramedic as their licensed care providers, what might be some examples of where EMS services fall? Sorry, Joel, if that wasn't clear, but what I mean was CHWs are not a licensed or certified type of worker, and so when you're talking about a CHW grant, that grant is not for those. But EMS services probably will fall under, they could be in a rural coordination, that that money, that 10 million, I think it was, pot for regional programs to increase access. Probably it would fit there. There might be some other places that specifically call out EMS. I think there was at least one. I think that was the one that I just named. Reach out to us if it's unclear, or Mary may have some more information for you. But we can help guide you in how best, what we think is best, the best way to target that. Use as a match for other federal grants, Sharon. I do not know. That's a good detail, but and hopefully it's in the RFP information. If not, we can help you track it down. I don't know if you will be able to use these funds as a match for other federal grants. Kevin has listed in the Q&A a number of organizations that are eligible for the CHW grants. Again, they're going to have to use CHWs to do something, but these are the organizations that are eligible to access that money. Okay. I think then that we are, okay, one more. Stacy, can we submit grant requests to more than one area? Can we get more than one award? I believe, my understanding is that yes, you can, but that's exactly something that I would expect to be posted in the RFPs. If you can't find out, I don't know offhand if anything is specifically excluded as far as doubling up or going after different awards in different areas. You may only be able to win one, but you can submit more than one. I just don't know. Often in RFPs like this, that detail is in there. If you have any trouble finding that out, Stacy, reach out to us or reach out to Kevin, and we can, I'm sure, figure that out one way or the other. All right. I think things are petering out here. I have no more open questions. So we will go ahead and wrap that up, and all of us have some homework to do. So encourage you, I'll stop my share. Is there, Mary or Kevin, does one of you Kevin, you want to post that link one more time in the chat for anyone who didn't get it? Though I suspect we did. And like I say, these slides will be available. What we'll try to do also, if we remember, is to tack on a link to the posted RFPs. If you don't have it already, and Google will help you out here, just look for Wisconsin Rural Health Transformation Program. Takes you right, well, should take you right to that page. You'll be able to find it at DHS, and you'll find links there to all of this material. Again, thank you all. Oh, there's a Q&A. I'm going to jump back in.
That's the post from Kevin.
So in the Q&A, there's a post from Kevin Jacobson about where to find those RFPs. All right. Thank you all for attending. Thanks for your interest. Good luck in your applications, and please do reach out if you find yourself needing some help, some guidance, you just want to bounce some ideas off, you want to pull together a regional project, and you need to know where to start. Let us know. Let us know how we can help, and we're happy to do that. Mary, anything else you want to end with?
I think that's it. Thank you all for joining us today. As Jonathan said, we will get these the recording and the slides and the links out to you all hopefully within the next couple days. We wish you good luck with all of your grant writing.
All right, take care, everybody.
Thank you.